Hello and welcome back to the ECG course. This is chapter 13, and in this chapter we're going to be talking about paced rhythms. And we're talking about implanted pacemakers, not transcutaneous pacemakers where we put the pacer pads on the skin. Those rhythms we know are going to be paced, and that's a whole different topic. Implanted pacemakers, usually you'll have a patient that'll hopefully be able to tell you that they have a pacemaker. If not, let's say they're unresponsive for some reason, you can identify on a lot of these patients a pacer pouch where you can actually see the device underneath the skin. And that device is, a little pacemaker, and what it's doing is it's sending out a signal through a lead wire that's connected somewhere into the heart, and that is creating cellular depolarization from outside means. So our normal physiological pacemaker is typically the SA node, right? But if that for some reason is not working, and the rest of the conduction system isn't working that effectively, you might have a implanted pacemaker put in by a cardiologist. And there's different kinds. You could have a lead wire to the ventricles, you could have a lead wire that goes to the atrium, and we're going to talk about those different types of pacemakers. The first one we'll talk about is the atrial pacer. And this is actually a very desirable type of pacemaker because you're using a lot of the normal physiology in the heart. Most of your conduction system is still working pretty effectively with this atrial pacemaker. And the first thing you should probably be able to notice that's different on this rhythm than any rhythm you've seen so far that we've talked about are these little spikes, these straight lines before the P wave. And it's going to be before the P wave with an atrial pacemaker. You're going to see a spike just like that, and that's creating, that first signal sent by the pacemaker to start cellular depolarization in the atria. Okay, so that lead wire goes into one of your atrium, your right or left atrium, and it's causing depolarization to begin each time it sends that signal. So that pacer's firing, and it fires around 60 to 100. Okay, pacemakers used to all be set around 60. Now there's different rates. Okay, so you're going to determine the rate, and that rate that the pacemaker's set at is probably going to be the patient's heart rate. Okay, the rhythm should be regular. The P wave is present with an atrial pacemaker, followed by usually a narrow QRS complex, less than 120 milliseconds. And then, of course, you have normal repolarization after that. So this looks a lot like a sinus rhythm, except you have those spikes before every P wave. So ask your patient if they have a pacemaker if you see that. The next one we're going to talk about is an AV sequential pacemaker. It's not as desirable as an atrial pacemaker, but it is another sort of backup system if the ventricles aren't depolarizing on their own. So an AV sequential pacemaker is just like that. AV stands for atrioventricular. So you have an atrial pacemaker and a ventricular pacemaker. It's all coming from the same machine, but you have two different lead wires. One that stimulates the polarization of the atria. That's why you get a P wave after that. And then another little spike followed by a QRS complex because it's stimulating the polarization of the ventricles. And you'll notice that when the QRS complex immediately follows the pacer spike, that it's going to be wide. You're going to have a wide QRS complex. Now think about the reason for that. Whenever something's wide in EKGs, it means it's taking longer to happen. So when the ventricles depolarize, and it takes a little bit longer for them to depolarize, you get a widening of the QRS complex. And here's why. That pacer wire is not starting that wave of depolarization in the normal lane of conduction. So we've talked about the normal lane of conduction with the His bundle and the bundle branches ending in the Purkinje fibers in the ventricles. That's your highway in the heart. That's the highway, the fastest way for conduction to travel. But it can still go outside of that and travel from cell to cell to cell, which takes a little bit longer. So imagine it as almost taking the back roads instead of taking the highway. And just like if you get off the highway in your car and you have to take the back roads and you start hitting stop signs and street lights, it's going to take a little bit longer to travel, right? Well, same thing in the heart. When that lane of depolarization or that wave of depolarization leaves that fast lane of conduction or that highway of conduction and it goes from cell to cell to cell, it takes a little bit longer. And that's why these ventricular pacers are going to take a little bit longer. So that's what your AV sequential pacemaker is. You got a lead wire in the atria and a lead wire in the ventricles, and it's depolarizing, and they're set to depolarize at that PR segment time. So the atrial will depolarize from the pacemaker, and then it'll send out that next signal spaced out, less than 200 milliseconds. So it'll hopefully get that full filling of the ventricles using that sequence. The ventricular pacemaker, ventricular pacer, is a little bit different in the fact that it's not depolarizing the atria. Okay, so it's probably the least desirable of the three that we've talked about so far, because the ventricular pacer is not depolarizing the atria, it's just depolarizing the ventricles. In fact, it's very similar to having a ventricular rhythm. The only difference is it's not happening intrinsically within the heart, it's happening through that mechanism that has been implanted in the patient, and because of that, the rate can be controlled. So that rate, again, is going to be usually around 60 to 100. The rhythm will be very regular. The P waves will be absent. You won't see any P waves because you're not having atrial depolarization occur before the ventricles. And your PQRS ratio, because you have no P waves, you have no PQRS ratio or no PR interval either. And again, your QRS complex is going to be wide because we're outside the normal lane of conduction. With a demand pacemaker, it can be any of the ones we've talked about so far. Usually you're going to see this with ventricular pacers. They can be set to a demand mode. Okay, so this example that we're showing here is obviously a ventricular pacer. You see a pacer spike, and then you see the wide QRS complex immediately following it. But then you notice right here, in this area, and right here, our rhythm became irregular. The pacer did not fire here or here. So it didn't fire in this area or in this area. And the reason that the pacemaker didn't fire is because the patient's heart decided to create its own pacemaker and kind of fill in the gaps there. So what happened is the heart's conduction system, or the heart's automaticity, still kind of effective in a sense here, decided it's going to go ahead and depolarize. Well, the pacemaker being set to a demand mode and being pretty smart said that, well, if the heart's already firing right here and it's already sending out a signal, let's let that happen. Let's let the ventricles depolarize on their own, and then we'll come back in if it takes too long to happen again. So this patient's heart rate, if the heart rate goes down below a certain number, this pacemaker kicks in and kind of fills in that void. So let's take a look here at different paced rhythms. We've already identified the many different kinds of pacemakers. And here we could see we have what looks like a sinus rhythm, right? You see a P wave, a QRS complex, you see a T wave, all that T wave is inverted. But before that P wave, we see big old pacer spikes, don't we? These are big, gigantic pacer spikes. So this here would be an atrial pacer. It's an atrial pacer. Let's move along. All right, here we haven't talked about this. You see pacer spikes, but you don't see QRS complexes or T waves or anything else. This is a pacemaker that's not capturing. Okay, so this would be what somebody would look like if they're in asystole. Asystole is a lack of any electrical activity, but their pacemaker is still firing. So those pacemakers, they generally don't pay attention to whether somebody's alive or not. So if somebody did die and they've been dead for a while and their pacemaker still kept firing, this is what it would look like. It also could be somebody that's completely on, completely dependent of their pacemaker. Their wire could have become misplaced, or they could just be losing capture for some other reason. Hyperkalemia is actually quite a common cause for losing capture with an implantable pacemaker. So this is a failure of the pacemaker's capture, and this should cause serious concern. You may be doing CPR at this point. Okay, here hopefully you're able to identify this one. This here is an AV sequential pacer, and this is an AV sequential pacer that is a demand pacer. You notice that right here we did not have pacer spikes because this is the heart's own beat going and taken over right there for that one single QRS complex. The heart decided to send out its own beat, and this pacemaker just filled the gap after that and kept the rate normal. Okay, here we haven't seen an example of this. This is a ventricular pacer. Okay, you see a spike and then a QRS complex after that. And then you see it over here as well, spikes and QRS complexes. But you also had failure to capture. You had failure to capture here. So this patient you would want to take in to a cardiac facility where they can see, hopefully, their cardiologist about their pacemaker and see what's going on. I don't know what kind of tuning they would have to do, but hopefully fix that and get them back to 100% capture. This next example, we have a captured beat, a ventricular pacer with a captured beat. And then, this is almost like a fusion beat. The pacer fired, but it shouldn't have because we have, this is obviously a physiological beat as well as this one and this one. So this is the patient's own intrinsic rhythm. It's a normal sinus rhythm. And it appears that they probably have a demand pacemaker. And that pacer spike still fired. And of course, it finally realized that it shouldn't be firing for some reason, and then the normal sinus rhythm continued. Okay, so this patient also you would want to have seen, and if you were lucky enough to capture this EKG strip, that could be shared with the cardiologist. Moving along to the next one, here we have looks like a pretty fast rhythm, pretty fast rate for a pacer. But it is in fact a pacemaker. You notice how small those spikes are compared to the ones we've seen so far. Those little pacer spikes are in fact coming from the pacemaker. You'll never see the heart itself just cause a straight line like that. It always has a little bit of a slope. Even if it's the most minute slope ever, physiologically, you won't ever see a spike come from the heart's conduction. So this is a ventricular pacemaker, and there are reasons where pacemakers will speed up the rate, the underlying rate, and the reason could be because sometimes patients will go into a rapid rhythm and the pacemaker will do something called override pacing. Okay, and it will start to speed up the pacer rate to kind of override whatever the patient's underlying rate is. So if they were in a heart rate, if they were having a heart rate of 160 and the pacemaker said that's too fast, the pacemaker might speed up to 170 and then take over the rate and bring it down. So watch out for override, or sometimes called overdrive pacing. A lot of times people call it overdrive pacing. Okay, here's another example. And here we have a pacer spike, a P wave, and a QRS complex. So hopefully you're able to identify that as an atrial pacer. Okay, and then notice you do not see that here. It may have been a failure to capture that by the monitor, or that could be a failure to actually send the pacer signal. Okay, but we do not see a spike before that one. A lot of times you'll notice that when you have somebody with a paced rhythm and you look at it on the monitor and you print out an EKG, you'll see pacer spikes, and it seems like you could see them in some leads but not in other leads. Always choose the lead to monitor where you could see them the most clear, and that's kind of true for all rhythms. Pick the lead that has the biggest QRS complexes and the easiest to identify P waves when you're trying to interpret those things. Don't use the hardest lead to determine the rhythm. A lot of times lead 2 is not the lead you should be monitoring in, although that is what most EKG monitors will default to. You should often change that lead and see if there's another lead that could be better to identify your rhythm in. Here again we see those 2 spikes before every QRS complex. It's really difficult to identify the P wave here, but there is a little tiny P wave following that first spike. This is an AV sequential pacer. Notice the ventricular spike is causing that widening of the QRS complex. So this is an AV sequential pacer. This patient is 100% paced at this point. Moving along, here we have another example of an AV sequential pacer. Again, you have that atrial spike, you have that ventricular spike, and you have a widened QRS complex as a result. And notice that this rate is different from the rate we just saw. Look at the rate here. You can see it's much faster than the rate we're looking at. Again, that's very dependent on the pacer settings. Okay, here we have another example of a pacemaker. We see widened QRS complexes. That should always make you sort of assume that it's probably going to be a ventricular pacer, and then you do see these spikes occur immediately before ventricular depolarization, which tells us that this is in fact a ventricular pacer, And since we did have one intrinsic beat that did not occur as a result of the pacemaker, we can say that this is a demand pacemaker. So this is a ventricular demand pacer. And one final one, we have another ventricular demand pacer. We have a spike, we have a widened QRS, and we can see here we have a couple beats where we did not have a paced rhythm, and then we went back into the paced rhythm. So what happens is the patient's own heart rate came up, so the pacer stopped firing for this period of time here, and then the patient's heart rate slowed down, so the pacemaker decided to kick back in, and that's what they're designed to do. They're designed to keep the patient within a normal heart rate. And that's it for now. That's it for paced rhythms. They're really not that hard to identify as long as you get used to looking for that pacer spike and asking your patient if they have a pacemaker. But remember that those pacer spikes are getting smaller and harder to identify. So your monitor hopefully is calibrated to, identify those, but sometimes it will miss them. If you want to go back and check out Chapter 12 again on ectopy and aberrancy, click on the image to the left here. If you're ready to move on to the next chapter, we're just going to talk about asystole and some artifact stuff. You might already be familiar with a lot of that information. As always, subscribe to the channel because I'm always updating videos. This is just the initial course, so there's always going to be added videos on different topics. I certainly am going to add some more videos on AV blocks and on wide complex tachycardias and narrow complex tachycardias to sort of kind of fill in the gaps of a lot of stuff I haven't talked about yet. So make sure you subscribe so when those videos become available, you can check them out.